Thank you very much. A good start to the morning, and we'll have plenty of time for questions at the end of this session with the panels. Next up is Andrew Vickers, who we heard a bit from yesterday from Sloan Kettering, who will be talking to us on clinical research data sharing practices and attitudes. Andrew?
Where's the clickers here? Yeah, so I don't know if there are any junior faculty in the room, but if you want to get invited to the Institute of Medicine, perhaps it's the paper in the New England Journal of Medicine that you don't need, or the Journal of the National Cancer Institute, but something in the New York Times. This is something that I wrote out of frustration. There's a lot of consumer advocates here. I guess I'm a consumer because I'm a statistician, and there's the thing like you like your own data best. You don't want other people playing with it. Well, that's what I do. Is I play with lots of kids. I play with data, and whether it's my data or other people's data, that's not what is important. And so I wrote this paper. I don't actually know that much about data sharing. They were talking about HL7 and CDISC yesterday. I had no idea. I just come from it as a statistician trying to do research. I really believe that the more people we have looking at data sets, the better off we'll be. And I was getting very frustrated. This was a good few years ago, but 2008, over the first few years of the 2000s, I got an extra few minutes now.
Right? I took it away from you.
There you go. I'm Andrew Vickers, and So what was the sort of typical experience I was having? So somebody said, could you design a study for us? Could you do a power calculation? I'm like, oh yes, I'll need the variance of the endpoint in the placebo group. There was this trial published at the NIA. You know what? I could call those guys. They could send me the data set. I could get the variance, could do the power calculation. As an NIH researcher, NIH-funded trial, I am not prepared to release the data from the control group at this point. That was it. Blunt rejection. This was another experience I had. It's a big problem when you do meta-analysis, when you combine data. So we had a whole bunch of trials that said, did the patient experience, basically did the patient throw up during chemotherapy? The frank emesis is actually the term that they use. And then this one trial, very nice trial, I think it was published in JAMA even, said, well, how many times did they throw up, the mean and standard deviation? We couldn't combine the two bits of data, so I wrote to the PI, who was great, and she said, it's a great idea to do a meta-analysis, it's very important. I'd love to send you the data, but my statistician won't allow it. This was a Cochrane review. I think it was actually published eventually in the Journal of the Clinical Oncology. How is that helping science? I don't understand this. We're trying to put all the data together, right? You never learn, the baseball season just ended, right? So meta-analysis is when the baseball season ends, and you can't look at individual games. You've got to look at the big picture. Anyway, someone talked about, Dr. Eichler, is that how you say it? Dr. Eichler was just talking about looking at data sets to build predictive models. So this is something that myself and a colleague, Mike Catan, were looking at in the very early 2000s. And we were trying to come up with some ideas of how you would mine existing randomized control trial data to say who would benefit and who wouldn't. And it's all very technical statistical theory here, and we needed a chemotherapy data set, and so I remember a 1-hour phone call with the PI of one of the NIH-funded federal money cooperative groups, and they were just, we don't know about this, So we started begging, right? This is roughly what we said. We will do anything to get this data. We will corrupt it. We'll give you veto power. We'll corrupt it. We'll expressly state in the statistics in case a patient goes and reads in Biometrics, this technical journal of statistics. We'll say, look, you can't draw clinical conclusions because. And we never heard back from them. We weren't able to get this data. So when I wrote all this stuff, I wrote a paper in Trials, and I wrote this in the New York Times. I was treated by some statisticians as the kid that no one would play with in the schoolyard. He just is unpopular. But I want to say I do this all the time, right? I mean, I think probably I'm half successful, half unsuccessful. But I'm PI of several very, very large collaborations that have been very, very successful, have led to some very, very interesting results. The bottom one is that, really, we got a lot of institutions to provide their data to MSK. I think it was a total of 9 different institutions to show that there are absolutely massive differences in cancer recurrence rates between surgeons depending on their level of experience. It's actually, in Europe, it's actually starting to change practice in the way that surgeons are trained and the way that they organize specialty care. So I've also reanalyzed, individual randomized trials. This was from something called the Prostate Cancer Prevention Trial, a large NIH-sponsored trial. This was from a Scandinavian group. These are all interesting findings. This current guidelines, or for years, would say that how your PSA, which is used to detect cancer, how that changes, its velocity can tell you whether you've got cancer. We reanalyzed this data, said it doesn't. It's come out of guidelines. Here we showed that actually, overall, most men with prostate cancer don't need to be treated. But if you do need to be treated, yes, you really need surgery. And this was very, it's what everyone had suspected. It was confirmed when we reanalyzed the largest randomized trial that had been done to date of surgery versus observation. So what are the arguments against data sharing? Remember, I'm mainly dealing with academic data. I very rarely approach drug companies for data. So what do the academics say? And I know not just because of anecdotal experience, but with Caroline Savage, who's now Caroline Bennett, we published this paper where what was the experience of trying to actually get data, all from academics. Published, and we chose it in PLOS because Public Library of Science says, you must give the data. If you publish with us, you must get the data. And we actually found only 1 in 10. We approached 10 individuals, 10 papers. We only got 1 data set from a journal that said, you must share your data. So we know what everyone said, right? So what were the sorts of things that they were saying? I'd love to help you. I really support what you're doing, but it's very busy. I'm just teaching now. I've got a grant due, and so on and so forth. Wait a minute, putting together a data set. You just published a paper. What was that based on? You've got to do this anyway, right? I'm a statistician. I publish papers the whole time. We have a clean and well annotated data set. And if anyone wants that data set, I'm like, here it is. We've sometimes had that. We published a very controversial paper comparing surgery with radiation oncology, and the radiation oncologists were freaking out. Well, here's the data set. Have a look. It's totally understandable. Just to give you an example of one of the things we did, here was a study we published in one of the BMC journals, and you can add additional files, and you can download the file, and we put it in Excel format. I just cut and pasted it from Stata, which is a statistical package, into Excel. And then the variable descriptions, so that you could actually understand it, were also cut and pasted from the statistical software, because I've got to have this too. I've got to write this up for myself and for my staff. So that was about 5 minutes to actually, it wasn't $2.3 million or whatever they were telling us yesterday. We've actually done this, that learning curve papers, the 15,000 patients I was talking about, we actually, as an experiment, we said, well, here's a very complicated data set. There were 6 or 7 papers published on the basis of that data set. What would it take for us to de-identify those data, put them in a format anyone can understand, and publish all the code we used to analyze those data? And that is, we have a lot of tricks like subroutines that make everything look nice, but it's kind of difficult for somebody else to follow, so we had to take out all those subroutines and rewrite them. And you can find this paper. We reckon it took us about 8 hours of work, right, for 7 major papers in the academic sphere. Okay. Second argument against data sharing. I'd love to help you, but what about patient confidentiality? It actually reminded me once of my wife. She rang up, she got an appointment with the doctor, and she's just called on the phone to the secretary and says, oh, can I just ask, does he have board certification in whatever it was? And she was told, I can't tell you due to HIPAA regulations, right? Which just means, like, can I have some coffee? I can't give you the coffee because of HIPAA regulations. It's just like whatever. It's like a defense against anything. Okay, so just in case anyone's aware of this, let's go through step by step Here's a data set. On the left are 3 columns that in theory could be used to de-identify them. If you select them by selecting column A, B, and C, and hit the delete button and then the save button, we have now de-identified the data set. I do accept that it is sometimes more complex. This is the complete code we had to write to de-identify a data set. It's things like, I don't know if you can see that, does it have a laser pointer? I don't know. Yes, here we go. Young men and old men. Because prostatectomy is rare in young men and old men, if you were very young or very old, we reset the ages. If you were 32, we made it 40. If you were 78, we put it 75. Okay? I'm not stupid. I understand HIPAA. This is all the code. I mean, how much code is this to write? How long do you think this takes to write this code? It's really not very complicated. I mean, it's probably took less time than one of those conflict of interest declarations that you have to fax around the place. Another argument against data sharing, other researchers may conduct invalid analysis. Oh my God, something invalid happening in science. So this is personal interest to me. I recently published a paper. It was a meta-analysis. These guys, where did they come up with this idea of finding out how to do publication bias, right? There was a correction for publication bias, how many unpublished studies. They just pulled it out of their nether regions, okay? Why did we do this? Because it was in the study protocol that we'd published. We explicitly, 5 years ago, said how we were going to correct for publication bias, okay? Now, why was this person able to say in RCTs of 100 subjects? It was because in the paper we said only if there are 47 unpublished trials with 100 subjects would there be no difference between groups. Okay? So the person was only able to criticize us because we actually told us what they did. So of course we just should do this, right? We looked at the problem. We don't think it's a problem. If we don't say what we did in the paper, then no one can criticize us. And it's exactly the same with data, right? No one says don't publish your methods or results because people might do invalid critiques, right? Same thing in data. Publish your data, let people critique you, and then you can have a scientific debate about it. Someone might so this is more of a sort of drug company thing, right? Now, I haven't really dealt with too many drug companies, but I have heard arguments about it, in the New York Times article, we point out that there's someone called John Kerwin, who is a rheumatologist from New Zealand, had actually written to drug companies and researchers and said, would you share your data? Now, it's very nice to come here and have people from Sanofi and the drug industry say, yes, we'll share our data, because back in the early 2000s, 75% of drug companies and researchers said you shouldn't let data be open. And this is one of the reasons. Someone might delve through our data and find out our drug didn't work. Well, how's the secrecy working out for you, right? What about this? We looked at our data, and then, we really looked very hard to see if there were side effects, and then we made it available for everyone else to look at, okay? And we really couldn't find something. Something happened. We're sorry, we took all reasonable steps. What are you going to do? You cannot sue someone if they take reasonable precautions against something. I think data availability, I'm not a lawyer, but it sounds to me to be a pretty good defense against litigation. Okay? Secrecy has not helped the pharma industry, either in terms of just pure finances. I think, what did Merck cost? It cost them billions. I mean, billions and billions of dollars, something like $5 billion in litigation and fines and so on, or in terms of their reputation. Fifth one, data sets contain proprietary information. If anyone can explain this to me, maybe can you send me an email or put your hand? I don't understand what the proprietary information could be, really, okay? Maybe there's some marker in the data and you show the drug affects the marker and so you want to then build it, God knows, right? But I mean, this will be rare. If it happens, well, oops. If it is true, then maybe someone could make an argument that there is a small piece of proprietary information and we do want to hold it back. We're going to give you the rest of the data, okay? Researchers have a right to exploit data they've spent years collecting. I agree with this. This is an argument against data sharing, okay? We do need to incentivize people to collect their own data, but you can get over it, right? So we published the learning curve data set. I will always be the learning curve guy, right? I published the first paper. I don't really have to worry that my academic career is going to be derailed because someone does some reanalysis of something. It's very easy to have some kind of embargo period, publish your trial or whatever it is. You've got a year or two to exploit the data, and then anyone else can have it. And of course, academic credit. I mean, if someone were to publish a paper on the learning curve, I'd look terrific, right? And in fact, I think there's some people talking about how you can get academic for credit for reused data. We do know now that papers that publish their data are cited much more than papers that don't. So there's already an incentive there. Just so this was a paper we published, this is a good few years ago, in Trials. All these codes of conduct, what should you do with data? I mean, they're not difficult to work out. Things like, if you're going to publish a new analysis, you've got to contact the trialist beforehand, okay? Or they should be, journals need to offer a commentary and, so on and so forth. I think these are all solvable problems. So get used to it is my message, right? I mean, I was born in 1967, which was, I think, Loving versus State of Virginia. At the time, most Americans thought interracial marriage was like, come on. How could you even think about this sort of thing, right? It's exactly the same. Open access to papers, when that came out in the late 1990s, early 2000s, there was outrage, right? Clinical trial registration, okay? That was seen as a whole big issue that would damage the commercial interests of companies. A whole bunch of things seemed like very radical things at the time. I think data sharing is just one of those. Thank you very much.